So thank you for the invitation and for the organization of this very interesting workshop. So I'd like to present this work about a joint model for longitudinal marker and competing event with heterogeneous variance. This work was performed in the framework of the PhD thesis of Léonie Courcoul, who is supervised by Antoine Barbieri and myself, and in collaboration with the neuroepidemiologist Christophe Souriau. So what is the motivation, as often for all the model for heterogeneous variance? The clinical motivation is the link between blood pressure and cardio and cerebrovascular disease. As you know, this is a leading cause of mortality, acquired physical disability, and dementia. And so it is important to identify modifiable risk factors. Among them, high blood pressure is very well known as a risk factor for CVD, but more recently, blood pressure variability, as previously discussed, has been also identified as a possible independent risk factors because it can stress blood pressure, affect the heart, and cause damage to arteries. So to try to evaluate the effect of within subject variability on the risk of CVD, joint models have already been proposed, especially by Gao and collaborators and Barrett and collaborators previously. And their model are presented here. And we would like to extend this approach in several directions. The first one is that in this model, the variance is assumed to be, the within subject residual variance is assumed to be constant in time, while we think that in many applications, we observe an increase or a decrease of the variance over time. The model does not handle competing risk, and we have many applications where we have a problem of competing risk. And another important thing is that in this model, the risk of the event depends only on the random effect and not on the current value of the marker. And so the random effects are fixed in time. And so this means that the individual risk does not increase when the blood pressure variability increase or when the blood pressure level increase. It is assumed to be fixed over time, except for the baseline risk. So the objective is to propose a joint model for longitudinal marker and competing risk, which depends on the current value, the slope, and the intra-subject time-dependent variability of the marker, with some main features that are, we want a time and covariate-dependent residual variability. We want to allow flexible dependent structure and especially dependence on the current value and current slope of the trajectory, in addition to the dependence on the within subject variability. And we allow a flexible baseline risk function using spline and competing risk and left truncation. So the model is specified in 3 parts. The first one is a quite standard linear mixed model for the evolution of blood pressure over time. We denote YI tilde the current value of the blood pressure without the noise, so the current true value. The specificity of this model now is that we use a location scale mixed model, so that instead of having a constant variance for the residual error, we assume that the residual error, the variance of the residual error is modeled using the log linear model that may depend on covariate, denoted O, and fixed effect, and other time-dependent covariate M, and a random effect. Typically, M include an intercept and a slope, possibly other function of time. We have enough measurement for each subject. And the random effect for the mean and the random effect for the variance may be are Gaussian and may be correlated. The last part of the model is a cause-specific proportional hazard model. For each cause of events for each event. Here we assume that we have only 2 events. The risk follow a proportional hazard model, where the baseline risk is modeled using B-spline to be flexible and smooth. And we assume that we can have other time-fixed covariate, WI, and the risk of the event may depend on the current value of the marker, the current value of the slope of the marker, the slope of the trajectory, and the current value of the residual variance. So to estimate this model, we use a maximum likelihood approach. So the likelihood has a shape that is close to a standard joint model, except that now we have an integral over the 2 sets of random effects. On the first line, you have the contribution of the competing risk part of the model, and f of yi, given the random effect, is a Gaussian distribution, multivariate Gaussian distribution. To compute the integral, which is the main difficulty in this model, the estimation of this model, we use a quasi-Monte Carlo approach. For computing the cumulative risk, the 2 cumulative risks for the 2 events, we use a Gauss-Conrod approximation with 15 points. And we use the Markov-Levenberg algorithm, which is a robust version of the Newton algorithm for the estimation. So the procedure was validated by simulation, but I don't present the result. I want to focus on the application. So we applied this model to the clinical trial progress. This is a multicentric randomized double-blind controlled clinical trial that involve subjects with an history of stroke or transient ischemic attack within the 5 years before the inclusion. Subjects were followed up for 4 years and a half, with 5 visits for the first year, and then 2 visits per year. And we included in this analysis 3,710 patients. We observed 672 CVD events in this during the follow-up, and 150 deaths from other causes. Note that deaths from CVD are included in the first event. So the estimated model is the following. We assume a linear time trend for the blood pressure with random intercept, subject-specific random intercept, and subject-specific random slope, a treatment effect, and we assume a log normal model for the variance of the residual error, with also a linear time trend with a random intercept and a random slope, plus a treatment effect. For the 2 events, we assume a proportional hazard model, and the risk of the event may depend on the treatment, on the gender, age, on the current value of the blood pressure, the current slope of the blood pressure, and the current variance of the blood pressure. So we compare this model with a standard joint model, assuming a constant variance for a constant residual variance. And we observe that according to the AIC, our model is better. Here are the estimation of the parameter for the mixed model. So we observe that we have no time trend for the blood pressure in this sample, but we observe that the treated group has a lower blood pressure. And regarding the modeling of the residual variance, there is a trend to an increase of the variability with time, but not significant. And the treated group also has a lower variability. So probably the most interesting results are stable. These are the parameters for the 2 survival submodel. On the top, the model for the CVD, we observe that the blood pressure current variance is associated with the risk of CVD. An increase in the blood pressure leads to an increase in the risk of the CVD. There is no association with the current value of blood pressure, and there is a paradoxical association with the current slope of blood pressure, because when the blood pressure, the slope increase, the risk decrease. This was not expected. Regarding the CVD, we observe similar result. Stronger association, in fact, of blood pressure variability with the risk of death from other causes. The parameter is larger compared to the one for CVD. And we also observe two association between current value and current slope in the direction that an increase in blood pressure leads to a decrease in the risk. And a point that is important is that this paradoxical result for the level and slope are not due to the adjustment on the variance. We have the same result with a standard model. So to evaluate the fit of the model, we compute the predicted value of the blood pressure given the random effect. The random effect are estimated by maximizing their posterior distribution given the data. And we compute the prediction interval by computing the variance of YIT given the random effect. And to illustrate the impact of modeling the variability, we compare the observation for 4 selected subjects and the prediction coming from the standard mixed model and from the location scale model we proposed. And as you can see, the prediction from our model in blue better reflects the variability of the subject that may be increasing or decreasing depending on the subject. We also compute the predicted risk of event between window S and S plus T given all the measures collected until time S. For doing that, we use a Monte Carlo approach. We generate first the fixed parameter according to their posterior distribution. Then we compute the predicted probability, and we compute the confidence interval using the percentiles of the empirical distribution of this probability. And to illustrate again, we have on the top a subject with a large variability, and on the bottom a subject with low variability. Both have a similar mean level of blood pressure. And on the right, you have the predicted survival probability, no, the predictive cumulative risk on the for CVD. And you can see that our model predicts a higher risk for the subject with a large variance and a lower risk for the subject with low variance compared to the prediction obtained with the standard jump model. But this is more clear for the other event because the association of variability with the risk of death was larger than the risk of CVD. And so for the same subject, you observe a larger difference between the two models. So to conclude, regarding clinical result or epidemiological result, we observe that blood pressure variability is a risk factor for CVD and for death without CVD. And we also observe that blood pressure variability is lower among treated subjects. The main limit of this work regarding the application is the fact that we have a highly controlled population with a history of a stroke and with a close follow-up and management. And so maybe these conclusions are not extrapolable to general population. And regarding methodological result, the important thing is that we can have a covariate and time-dependent variance, a flexible dependent structure between the risk of events and the evolution of the markers. And we can also implement goodness of fit criteria, even if I think that the evaluation of the fit regarding the variability is quite difficult. This work has been implemented by Leonie in a package that is named FlexVarGM, which is on GitHub and also on the CRAN. But she's currently in the process of extending this package. And in fact, all this capability will be included in a new package, LSGM, for location scale joint model, with other model developed after that. Thank you for your attention.